thank you all for coming. It's a wet evening, you've been at work or doing other things today, so thank you for coming out this evening to the Said. I want to talk to you tonight about the work that we're doing in our BRC theme, our Biomedical Research Centre theme. Now, BRC is an enormous research organisation. I only work in one little bit of it, but I think it's the most important bit. That's my bias. It's how we can deliver hospital care without you needing to go anywhere near a hospital. Now, this sounds like it's not possible. I hope to persuade you this evening that it is, but there are still some questions that research needs to answer, and that's what we hope to be doing in our research theme. So I work for the hospital, delivering medical care in its hospital at home and exploring how we can make that a very sort of dynamic service that can meet needs as they change, and our population needs have changed quite quickly, particularly with the COVID pandemic. Although I work at the University of Warwick, the research is based in Oxford, and it kind of shows that the BRC is working collaboratively, both mainly within Oxford University, but with other universities where that makes sense for the BRC to help deliver its aims, particularly working in partnership closely with the hospital, making sure the BRC helps the hospital change and adapt for the future as our populations change, as new technologies become available, and as knowledge expands. So, can we really replace the hospital? Well, you'll decide by the end of this talk. There's probably one thing to say is that I am the president of the Hospital at Home Society in the UK, so I love hospital at home, so that's my bias. So you'll have to interpret everything I say with that lens that I'm a big fan of it. So what does hospital at home involve? Actually, it's just the things that would normally happen in the hospital, only we do it where you live. And that could be in your home or in a care home. And you could be anywhere in your home. It could be in your front room, in your back room, in your sitting room, upstairs in your bedroom, in your basement even, it doesn't matter. And I hope to show you some of the technologies that allow us to deliver what you get in the hospital. So think about the assessments that you get in the hospital. Someone will take some blood. The blood result will come back very quickly. You might get a scan. A doctor will see you, a nurse will see you, other members of the healthcare team will see you. And we hope to use the technology, or I'll show you this evening, how we can do all that without you needing to go anywhere at all. And some of our diagnostic tests will support that too. Also treatments. So you go to hospital. Most people go to hospital and stay overnight will have an intravenous treatment, oxygen, things like that. Probably some medications may be altered that you take normally. And so we're going to show you how we deliver those in the home. Things that you think would normally could only happen in a hospital setting, we can do in the home. We'll show you what we put around you to help you do that. The other thing is about monitoring, and we'll move on to some of the research as well. Because obviously you get a lot of monitoring in hospital, your blood pressure checked regularly, oxygen levels checked. That we can do in the home setting. What we don't yet know is how well and the best way to do that helps us make the right decisions and helps you feel secure and have confidence that what's happening is right for you. So, there are various ways in which we can replace coming into hospital and still deliver what we need to do in order to work out what's wrong with you and to give you treatment. So, on the left here is your home, and on the right is the hospital. So what are the different ways in which we can replace the hospital? So firstly, let's imagine that you've come to hospital. This is you sitting in your bed in the hospital being assessed. Let's say it's in the emergency department or one of our emergency assessment areas. And let's say, well, we think you can go home, but we still need to do something with you to help you get better. So the one thing that we're doing a lot of recently that's not hospital at home, but similar, is called ambulatory care. So we'll send you home from the hospital that day, but you have to come back to the hospital for ambulatory care. So you'll come back to what I call our same-day emergency care unit. And if anyone of you been to the JAR and had this, it's what's called our AAU, our acute assessment unit. So you'll come there, you might have some scans done, you might have some treatments done, and then you'll go home again. So you do the moving around. We have the luxury of sitting in the hospital with all our scans and tests. We'd have to go out to the cold or the wet. We make you do that. It's called same-day emergency care. Now, the other thing that we could do to try and replace some bit of hospital care is say, well, let's say you've come into hospital and you've stayed overnight and you've done some things, but we think we can deliver the rest of your care outside hospital. So then you might come in for a few days and then go home. But then we would need to come to you, and that's called what we call early supported discharge. So things still need to happen, you still need injections, or you may need some other form of treatment, but we come to you in your home. That's called early supported discharge. But we've made you come to hospital, we've made you sit in our beds, we've done things to you, and then you're allowed out to go home, and we come to you. These are some of the nurses and our pharmacist here. I'll talk about that special treatment that we gave in the home a little bit later on. Now, the next way, I think, is the best thing that we could possibly do, which is the full replacement of the hospital. You don't go anywhere. Don't put your coat on, don't get cold, don't get wet. We come to you and bring everything that the hospital does to you at home. That's called like full replacement of hospital. So we have to come to you. But to do that, we have to bring everything that helps us make a decision about what's wrong with you and bring all our treatments so we're at the moment we know what's wrong, we can start treating you. We don't want the situation where we find out what's wrong, we have to get in our car, drive back to the hospital, find the drugs, then come back to you. We have to take everything that we need and give it to you at home. And that, what we call, is full replacement hospital at home. And that's what we're trying to do, because then it's much more convenient for you. You don't have to go anywhere at all. And there's no delays, we can treat you immediately, and it helps us meet the needs of our population with a fixed number of hospital beds. Because as our population grows, we're not able to grow the hospital. As we get older and more complicated, we can't add on more beds. We can't do loft conversions for the JR. We're stuck with it. So we think, well, actually, how do we find out what it is that meets the needs of our population, but still enables you to get what you need, but you can be the comfort of your own home, if that's your choice. If people want to come into hospital, they can. I say to all the patients I treat, the choice is yours. I can make a bed for you in the hospital, that's fine. But the choice is yours. And it's important that we can give people that choice. So, I thought, as it's a research talk, well, there'll be one figure and one graph. And the rest of it will be pictures and me talking and a few other bits and pieces. So, a real delight to have Professor Shepherd in the audience, I've just noticed, because I'm about to talk about her trial. And she can tell me if I've got any bit of it wrong. But the largest ever trial in the world of hospital at home was run from Oxford by Professor Shepherd. Sorry, I don't mean to embarrass her straight away, but this is a real exam test here. The largest trial where patients were randomised, the toss of a coin. In other words, people who need to come into hospital could either go home or come into hospital. And the trial was trying to balance and say, well, what are the pros and cons of either, of being at home and getting treatment or coming into hospital and getting treatment? And the main take-home messages for me from this trial are firstly that if you're treated at home compared to hospital, actually there's no extra risk. The mortality, in other words, the risk of the outcome we're all trying to avoid, which is coming to the end of life, and I work in the Department of Geriatric Medicine, so a lot of what I do is often actually around that management of how we recognise and treat people who are coming to the end of a natural life. But there's no difference in that, whether you're at home or hospital, in the services that were studied in this trial. I see a lot of patients who, as I say, are older and are frail, and they get quite confused with acute infections or with their biochemistry. In other words, all the salts and the kidney function in their blood isn't quite right. And if they're on the wrong medications, that can cause confusion as well. But if you're treated at home, fewer patients have that confusional state that we call delirium, and that's much better for patients. Interestingly, and this is a really interesting finding, I think, is that if you are treated at home rather than hospital, then if you look forward about 6 months after that illness that brought you into that trial in the first place, fewer patients went from being home to needing to go into a care home. So actually their independence was maintained. And that's a really interesting finding and important, and patients tell me that for them is a very important outcome, that they want to live as independent as life as long as possible. And on average, I mean there will be some different assumptions, but on average it's a bit cheaper, about £2,000 per patient if you're treated at home compared with hospital. So it's no riskier, it's a bit better for you, and it's cheaper. It's more complicated than that, as Professor Shepherd will be able to find around. But for me, those are the main take-home messages.
Oh, you didn't mention the time period for 2000.
Yeah, I'll come back to that. So this is the one figure I'm allowed, then we'll be talking about a graph. So the research group I'm in is interested in kind of getting under the bonnet of the different hospital home services and saying, well, what are you doing? What can you deliver in the home? So I'll walk you through this. So here we asked all the hospital home services in the UK, what can you do in the home? Can you give intravenous fluid? Can you give intravenous diuretics, which is getting rid of too much fluid? Can you do blood tests in the home? Can you give oxygen? Can you give intravenous antibiotics? And then we worked out from all their answers, well, who can do what? So if you only give IV antibiotics, what about 18 services or so give only IV antibiotics. Some give antibiotics, oxygen and diuretics, but nothing else. There's a few of those. So each of these is all the different combinations, that the sort of pick list that services have decided they can do or not. Now, there'll be no surprises of who can do all of them. I shan't name the service, but hopefully you'll be able to guess by the end of this talk which service that is. But it shows that we don't really have a national framework here. It's almost a postcode lottery. I know it's a very popular phrase in various tabloid newspapers, but it's kind of true. Depending on where you are and where you live and who works in the hospital at home service, they'll all be doing different things. I don't think that's a particularly fair way to go about things. Probably reason why we're studying this, we can say, what's the best thing to do? What's the best combination of tests, treatments, monitoring, and who should we be seeing at home? So let's talk about the things that we can do in the home. So blood tests. So some of you may have been to your GPs for a blood test and been told to ring up for the results in a few days' time. And that's often how people think about blood tests. It must take a few days. There's people with pipettes looking for things to change colour. I think of GCSE chemistry or O-level chemistry, depending on your era. But actually, you can get results in a couple of minutes. And it always amazes people when we're on the sitting room floor, on the shag pile carpet, we've got the biochemistry analyzer going, and in 2 minutes' time, here's all the salts in your blood. Here's how your kidneys are working. Here's the level of inflammation in your body that we can now test in a couple of minutes. And so that's important for me as the doctor overseeing it. I need to know rapidly what is wrong and what is right, so I can make the right choices around treatments and talk about risk and best place to be treated. But we need to know whether what we do with our handheld analyzer on the carpet in your home is the same as in the amazing biochemistry department in the hospital. So we tested them. We did a bake-off between the handheld test that costs a few £1,000s for the handset versus hundreds of thousands of pounds this complex analyzer. And what we found is this. I'll walk to this graph. This is the graph that I'm allowed as well. So this is your level of kidney function, and basically lower is good, higher is bad. And this is how different is the handheld test from the lab test. And this is the percentage bias. So it's how much bigger or smaller is the handheld test than the lab test. It turns out that the handheld test is slightly bigger. In other words, it's measuring things in the blood that is to do with your kidney function and a few other bits and pieces of molecules lying around. But it does it in a consistent way. So we can always know roughly what the lab test is going to be based on our handheld. And we've been using it on thousands of patients now with making accurate assessments of what's going on with your kidneys, a key organ, we'll be looking at that later, that helps us work out how is this illness affecting you? What treatment do I need to give you to get your kidneys back into line to help you recover and to do that in your own home? So this is important work that we did in Oxford to understand how these tests behave, and it's now part of standard care. So it's research into practice, rapidly changing what we do and helping us deliver a whole new paradigm of healthcare. The next thing I'm going to talk about is imaging. Now, many of you would have had a scan with an X-ray or CT scan or an ultrasound, and you've had to go into hospital to get that. You have to drive, sit in the queue to get to the JR, try and find somewhere to park, wait to be seen, have the scan. You've got to take the whole day off, basically, haven't you? So the key thing for us around treating people is working out what is wrong. The ability to make a diagnosis is critical, because without that, I find it very hard to work out what the thing to do is. We can treat people in emergency depending on what we find underlying them, but actually, to get you better as quickly as possible, we need to know everything possible about what's wrong with you. If you've got an infection, where is it? Your kidneys aren't right, what do your kidneys look like? You're breathless, is your heart working okay? So the ability to deliver imaging is critical. And now, these tests are now handheld with what's called point-of-care imaging, an ultrasound probe, which I bought here. And it's about, so it's this big. It plugs into my phone. I'll show you all the things this ultrasound helps me do. So firstly, I can look and see how much fluid's inside your body. Like I said, how much extra fluid do you need to have the perfect amount of fluid to help you recover? In fact, it's better doing that with my ultrasound than it is on the ward using X-rays or prodding your legs or listening to your heart with my medieval tubes in the stethoscope. This is actually much more accurate than what happens inside the hospital. Don't tell the hospital that, but it's true. Is there a pneumonia in your big infection in your chest? Have you got too much fluid in your lungs? Is that why you're breathless? Ultrasound is the quickest and best way, better than a chest X-ray, which again is a traditional hospital method. Don't tell them. If you've got a problem getting urine out of your kidneys, that's a big problem in terms of, for older adults certainly, Is there too much fluid in your body? I can find that out at the bedside. Are your veins hard to find? Well, I can use an ultrasound and find it very quickly in your back bedroom, in the care home. How well is your heart pumping? Again, the same probe, you can do all that. Is there a blockage in your bowel? I can find that out with ultrasound too, quicker than a CT scan, and in your own home too. Do you need a catheter to help urine get out your bladder? Again, really quick to do that. And I've also diagnosed blood clots in the leg in the home as well. So very common things that we worry about on what's called the medical take, where people have acute medical problems and we're trying to work out what's wrong in the hospital. It's actually quite easy to sort out in the home once you have this technology. So I wanted to do a live demonstration to show you how easy this is. And I have another researcher from our BRC theme. This is Ben. Ben is donating his body to medical science for a few moments this evening. We'll let him have it back at the end. Could you get us onto the Zoom call? So this should hopefully work. I might put my glasses on. So if I go on to Zoom, hopefully this is all going to work. So Ben, should we start by looking at your liver? Let's do that. Let's look at your liver. So I want to show you how easy this is. Can be done in the home, care home. Even in the Said Business School, you can look at someone's liver, okay? So let's just get rid of that. Right, Ben. So very often when I see someone at home who's unwell, they're in their favourite chair, they're not feeling very well, and they don't want to leave their favourite chair. So we have to scan them as we find them. So the patient is king in the patient's home. Right, Ben. So you don't want to lie down on a bed as would happen in the hospital, so we have to work around you. You want to stay in your favourite chair. I've even scanned someone while they're watching the World Cup football game without them missing a second of the action, I have to say. So let's go, actually, right. So there you go, Ben. Let's get onto the abdominal view. So this probe, I just choose what organ I want to look at, select the preset, and it does the rest for me. So this is Ben's liver. We'll just put a bit more gel on there so we can get a nice view. Sorry, Ben, you're going to be covered in gel. Let's just lift this up a little bit. Okay, right. So that is Ben's liver. And there's a little, if we come down there, and that big sort of black pipe at the bottom there. Do you want to give me a sniff? That's Ben's inferior vena cava, which is the big pipe that takes all the blood from his legs and abdomen back into the right side of his heart. And then if we move back a little bit, we'll see a bit of kidney. Well, I think we'll do the left kidney because you've got a beautiful left kidney. Because the right one's hiding at the back, and I want to keep Ben as dignified as possible. But this is that's a nice view of the right, and there's a right hepatic vein going to the liver there as well. Good. Okay, so let's look at your spleen in the left kidney on the other side. Still in his favourite chair, not missing any of the football game he's watching. And let's have a look here. Okay, right. So, do you want to sit forward a little bit for me, Ben? Is that all right? Can still see the football. A bit more gel on here. Right, okay, that's grand. So, there. So that white thing in the middle there, that's the middle of his kidney, called the medulla. Now, the thing I worry about when I see an older chap whose kidney function is not working is whether he can get urine out of his bladder or his kidneys, because sometimes that can get blocked. And then that white thing in the middle becomes very dark and branching. We call that hydronephrosis, which is a key test that you have to do in hospital. But you have to ask radiology, send the patient to radiology, and then look at the result later, whereas I just get my probe out and do it in about 30 seconds in the home. So it saves everyone working out. Then we know if someone's kidneys aren't right, whether they need to go to hospital to get them unblocked, or whether actually there's no blockage there, it's around treating the underlying medical problem, infection, it could be dehydration, the drugs they're taking. So it's a key test for me, because about half our patients have problems with their kidneys, and I get a perfect answer at the perfect time, which means I know that I'll be on the right track to make you better. A bit of a spleen? Let's get a little bit of spleen. Your spleen's quite small because you're quite fit. That's fine. A little bit on there, just north of the kidney there. Should we look at your heart?
Sure.
Why not? Why not? So let's start with looking at. Actually, we'll do the parietal long axis. So if I just get to the middle, is that all right?
Where do you want to go?
There, that's okay. Brilliant. You can lean back a bit, not missing any of the footy. Right. This is called a parasternal activity. So that lovely thing beating away is his left ventricle. So the blood's come round from the heart, from the lungs into that side of the heart. He's squeezing it nicely there. And that thing flapping away is your mitral valve, ensuring all the blood's going in the right direction. Great. And one thing we often worry about, because I see a lot of people whose blood pressure is quite low, is there fluid around the heart? So to do that, don't mind me just shoving it under there, you can drop that now, is we do what's called a subcostal view, which is where I put the probe under the heart. So just might give you a nice view there. So I'm shining the ultrasound beam through the liver, and then underneath there I can see Ben's heart beautifully beating away. And I'm looking at the underneath of the heart, and this is where fluid will collect if it collects anywhere. So I can rule out pericardial effusion rapidly. So I have what you might call a supermarket sweep. I start here, the neck, go all around the chest, abdomen, back up again, the heart, and I've looked at all the organs, found some key things that may or may not be right. Is there enough fluid in the body? Is fluid in the wrong place? Is there infection? Is there fluid in a dangerous place, like around the heart, squeezing it when it shouldn't be? So I know, actually, do I have to send someone to hospital to fix something? And then we know why they're going. If they want to go, I've shown them why they need to go, so they're happier about going. Or we can say, actually, all the things I would worry about, I know aren't there, in which case you need the following things to treat you. Ben, thank you so much. That was great. Pleasure. Thank you. A round of applause for Ben, please. So I'm going to stop broadcasting and we can go back. Yeah, okay. Fine. So how has ultrasound helped us? Well, it helps us a lot in COVID. These are lung ultrasounds of patients that I treated with COVID at home who weren't very well. And this is an ultrasound of COVID, and what COVID does is it gives you lots of water in the wrong place, so it causes these funny, what we like call waterfalls in the lung, and also it causes these little blebs here that appear just under the surface of the lung. On the CT scans we did in the hospital, we know that COVID affected this sort of outside of the bit of the lung nearest the rib cage, which is the bit that the ultrasound probe is next to. So actually we could diagnose the problems with COVID in the lung with ultrasound in the home. And because we could do that, I worked with some colleagues in Birmingham, which was one of the first places that in the country to have a big wave of COVID, in City Hospital, in a very deprived area of Birmingham. And we counted the number of lines that we saw on our ultrasounds. So how many of those big vertical lines did we see, and also how much change of those little blebs under the lung that we saw. And we just added it up into a score. And we found that we could predict what happened next to somebody just based on the ultrasound as soon as they came through the front door, or equally, the ultrasound that we did in their own home. And essentially, the higher this score, then the worse the outcomes were that therefore we needed to do of the new treatments that were coming out. And this was happening at the time when the recovery trial, the big trial that was run from Oxford, was finding out all these great treatments that actually really helped. So we could work out which patient needed which treatment just based on the ultrasound and give it to them straight away. And Laura's here in the audience there, and you'll see a patient that we treated very soon. So we had with this powerful information combined with the results we had from the recovery trial, we're able to start giving hospital treatment in the home. This is a drug called tocilizumab, which had never been given in the home before for COVID pneumonitis. And we did it for the first time. This is a gentleman who didn't want to come to hospital, who was actually really sick with COVID, whose score was really high on the scores that we'd done. So we're putting all our research findings in together to do what we could to help this chap. And we spoke to our infectious diseases colleagues in the hospital. And we said, well, if he were in hospital, he'd get this drug. We said, well, he's not. Well, then take the drug to him. Well, why not? And it turns out you need quite a lot of this drug. The entire coffee table was used up with bottles of this drug to give him the right dose. And this is Sophie, our expert pharmacist, and Jason, one of our expert nurses, delivering this drug for the first time in the world. Now, the one thing that you'll note about hospital at home is that although there are these very expensive drugs that we use, other things, one thing you do need is this 30p meat hook, because the meat hook allows you to hang the monoclonal antibody or the crystallized infusion or the antibiotic up, and it's either to a lampstand or to a picture rail. There's one or the other always in the home somewhere. So never do hospital at home without your 30p meat hook. So this is our model of how we bring the hospital to you in the home. We're all based at the John Radcliffe, but our patients are not. Although we don't have our own ambulance, The nurses are in cars because they bring all the drugs and the heavy things. I'm on my motorbike, so I just turn up, do a scan and say this is what I want. The nurses do the heavy lifting. And we go and see the patients in their own home or care home. We do everything on the hospital's electronic health record. So it is as if the patient is in the hospital. I write exactly the same notes, exactly the same software for my patients, which I do because I do a few weeks of inpatient work a year. Most of my work's outside. But in exactly the same place. So we type, we prescribe, we administer, but the patient is in their own home, not in the hospital, but literally everything else as if they were. And also, because we write in this electronic record, it means I can ask a liver specialist or an infectious diseases specialist or a heart specialist and say, could you have a look at this and give us some advice? So because we think that being in the home shouldn't mean that you don't see a specialist if you need to. But what does see mean? Well, I'll show a video in a second that will tell you what seeing means, because the hospital has a lot of intellectual capital. There's lots of people that know lots and lots about particular disease or particular conditions. How can we help people in the home still have access to all of that without them going anywhere? And again, that's an important thing for us to do. So this video, which I think should now play, this is a Panorama team followed us last winter as we went around doing our hospital at home care. And the patients were pretty generous, actually. They were pretty sick. We hadn't seen them before. We were just turning up, having been referred them by an ambulance. And they were happy to be filmed. And the film crew were very good with them, actually. I was a bit worried that they would be sort of very BBC-ish, but actually they were brilliant. They knew exactly how to talk to people who were in distress, and it was really great to watch that, actually. But this clip, I think, puts together what it's like to have your blood test and your ultrasound and your treatment at home. So that puts it all together and shows you how all these things work together. So these are all the things, of course I need to give a bit of time for questions, I don't want to keep you too late. So these are the things that we can do in the home. Treat heart failure, treat infections, treat anemia. Often we have problems with patients who have cancer and have ions of calcium, we can treat those. We can give you oxygen. We have what's evolved our COVID bundle over time as more information's come out from the recovery trial. We can include all of that into our bundle of treatment. So you truly can have the choice. Where do you want to be? We can give all these things, whatever tends to make you better. Then you get the true choice of saying, where do you want to have your care? Rather than accepting, so if I stay at home, I'll take my chances. No, you should get what you want in the location that you want it in. And a number of societies have come together to work out, well, what is the actual essence of hospital at home? What should it be? And there's a World Hospital Home Congress that we're part of. And essentially, in order to say well, how we're placing admission, we've got to be delivering hospital-level diagnostics and hospital-level interventions. And the team has to be around you that has those skills to deliver those things. So it's not purely virtual care or purely remote monitoring. It's not primary care, but primary care is important. And it's not managing long-term diseases, but that's important too. It's got its own niche as our population is changing and as the stress on our hospital system is changing. It's making sure that we have the right formulation and concept that we can deliver care. But this is where the BRC research team comes in, because there's still things that we need to find out. We don't yet know the best way to monitor people who are treated at home. We can put a patch on you and know what your heart rate is every second, your spirit rate every second, but we don't do that in hospital. So we don't really know how that will help us make better decisions. That's an important thing for us to research. We know that people whose loved one is at home, and I tell this a lot because I talk to families and carers every day, and they tell us that while they may want to have their loved one, the patient at home, it adds a burden and a stress onto them. So we want to find a way, how do we measure that so that we know how it is and how we can intervene to do other things that help that. So people can no longer feel that actually they can just focus on being with the person to help them, because we know that keeping families together and loved ones together actually is important in recovery. We train nurses and doctors to either work in a hospital with all the kit and the stuff, or we train them to work in general practice where they don't have much around them in terms of diagnostics and they have to be thinking of lots of different things all the time and managing risk in one particular environment. But actually, I think this sort of care needs people who are comfortable in sort of both settings. But we don't train people for that. We're not as strategic in our training, and we need to rethink that. And again, hoping that our work will feed into that. And also, actually, how does hospital home best support the hospital? There are times when the hospital is completely full and not working well. What can we do at those points to help meet all the need in a way that keeps the hospital functioning for people that either choose to be there or need to be there in a way that makes for the best outcome, both for patients and for those people trying to work in this system that's quite complex and stressful at the moment. So, for those who want to look at that Panorama program more, there's a link there. And also, for those who want to join the Hospital Home Society, please do. We're desperate to have members of the public and patients who've had the service join us, so their voice is heard, and they can help influence the national agenda as well as joining and supporting us in our research. So I hope I persuade you that we can replace the hospital, but we still have more research to do to help us do that in the best and most cost-effective way possible that meets the needs and gives you real choice. And I think on that moment, floor for questions. Yeah. Thank you.